Hi, my name is Allie Frashino, and I'm presenting today on the nutrition interventions that took place for my case study patient. This was a patient that was diabetic, critically ill, and ventilator dependent, and his main issue at this time was pulmonary edema. So this patient was an 83-year-old male. He was admitted for an NSTEMI that was complicated by a respiratory failure secondary to the flash pulmonary edema. He had a very complex medical history, so just to touch on it, he had a whole cardiac history of hypertension, coronary artery disease. He had already had an MI in the past. He had AFib, he had a pacemaker, and he had severe aortic stenosis. He also had some obesity-related diseases, and he was obese. He had type 2 diabetes and obstructive sleep apnea. And then he had some musculoskeletal issues, including degenerative joint disease and his chronic lumbar compression fractures. And I just added an interesting category. In 1985, he suffered from multiple gunshot wounds, and he had some bullet extractions and a left lower lobe lobectomy, which I just included because I thought that was fascinating. I really wanted to meet him once he was off of the ventilator, but unfortunately I wasn't able to. So his nutrition history I obtained from his stepdaughter since he was not able to speak with me. She let me know that at home he followed a low sodium diet, limited his sweets. He had a great appetite before he came in and no noted weight changes. So I'm just going to go over some of those disease states that he was currently going through, including the NSTEMI, the cardiorenal syndrome, the flash pulmonary edema, and the type 2 diabetes. So the NSTEMI stands for the non-ST elevation myocardial infarction. So that is when the cardiac tissue or myocardial tissue kind of dies, it has necrosis without ST segment changes. So the ST segment is something that happens when your heart is beating. So if that changes, and it's just called a STEMI, that's a little bit more severe. So this can be caused by reduced blood flow to the myocardial tissue, and this injured tissue leads to ventricle dysfunction, which led to my patient's other issues. So for him, that led to cardiorenal syndrome and an acute kidney injury. So cardiorenal syndrome is an umbrella term for multiple conditions that involve both dysfunction of the kidneys and dysfunction of the heart, one typically causing the other. In this form, his acute heart failure resulted in acute kidney injury. So the way this works is when the ventricle starts dysfunctioning, as I mentioned before, it kind of changes the neurohormone activation. So vasopressin is released, the sympathetic nervous system acts a little bit more intensely, and the renin-angiotensin-aldosterone system is activated. So this all creates decreased renal perfusion, hypotension, so low blood pressure, increased renal venous pressure, and decreased renal blood flow, which causes the kidney injury with the decreased GFR and the impaired renal function. So his other issue that stemmed from this ventricle dysfunction was the flash pulmonary edema. So that usually is caused by left ventricle end diastolic pressure changes, which is LVEDP. And in the first stage, the left atrial pressure causes distended small pulmonary vessels, while at the same time, the left atrial and ventricle pressures change. So the pressure becomes stronger across the pulmonary bed and the pulmonary capillaries, which causes increased intracapillary pulmonary hypertension and increased transcapillary fluid filtration. In the next stage, there's some actual interstitial edema in the lungs. So the increased pressure across the capillaries causes fluid start to leak into the alveoli of the lungs. And then this alveolar flooding in the third stage causes the real problems associated with pulmonary edema, including decreased gas exchange, hypoxia, and dyspnea, a word I can never say. So his other disease condition that is kind of an underlying thing was his type 2 diabetes. And I think most of us are pretty familiar with how type 2 diabetes works, but just to go over it quickly, the insulin resistance due to genetic predisposition or the adipocyte hormones, adipokines, lead to beta cell dysfunction, reduced insulin secretion, impaired suppression of glucagon production, and decreased peripheral glucose uptake, less glycogen storage. So all of this leads to the uncontrolled blood glucose. So that's a little bit about his background. The timeline of the events and interventions all occurred between February 29th and March 4th. Pretty short amount of time. So the patient was admitted on February 28th with the N STEMI that I had noted. The next day, the flash pulmonary edema set in, so that caused him to be very fatigued and short of breath, so he got transferred to the CCU, or coronary care unit. So that's almost like one step more extreme than the ICU, even as the hospital I was at. The patient was intubated and sedated with propofol, and the nephrology team, the palliative care team, both began following him. And we were asked to hold off on tube feeding Rex during rounds when he first was admitted to the CCU because they weren't sure, he wasn't hemodynamically stable, and they weren't sure how he would really last. The next day, his condition stabilized, so they actually got ready to place the nasogastric feeding tube. And this is when I actually spoke to the stepdaughter about the diet history. His potassium, magnesium, and phosphorus labs were all within normal limits. That, in addition to having no weight changes and a good appetite before he was admitted, made me rank him low risk for refeeding syndrome. So we assessed his needs at 16 calories a day. We used the Penn State formula because he was obese, overweight, and he was intubated. And we planned to use Glucerna 1.5 because it was high calorie, low fluid since he had the edema, and Glucerna because he was a diabetic. So the next day, his diuresis had actually improved, so he had positive INOs. His heart failure had improved, and his pulmonary edema was improving, so he was really kind of starting to turn around. He was still intubated, but it was time to actually feed him through that NG tube. His BUN was trending up, which wasn't very good, but his propofol was decreased to 12.5 milliliters an hour as they were trying to wean him off a little bit. So we reassessed his needs as well. His protein needs remained the same because we used his ideal body weight. And the doctor actually recommended a full 2 liters a day for him because his diuresis had improved. So our initial rate, pictured here, we did 130 milliliter flushes with the Glucerna 1.5. We factored in the propofol, and we provided him 100% of his energy needs, 99% of protein needs, and just about all of his free water needs per the MD's recommendation. So the next day, I just checked in on him briefly. His labs that indicate refeeding syndrome were still fine. He only had 20 units of residuals overnight, so he was tolerating well. He wasn't having any diarrhea or issues like that. We reassessed his needs to 100 calories higher, but we didn't change the rate since it wasn't all that much of a difference. And his urine output was still sufficient, so they decreased his diuretics dosage. But he was showing a little bit of hypotension and a fever, so they were wondering if he had ventilator-associated pneumonia. So the next day, they deduced that he had cardiorenal syndrome when I read the nephrology note, so that was just kind of something to bear in mind. His urine output began trailing off, however. He was now on an antibiotic, and his BUN was still trending up. So the fluid started to become a little bit of a concern. His propofol was also decreased. So we spoke with the MD about decreasing his fluid to around 1,200 milliliters of free water a day, and we recalculated this rate. So this was all based on, we wanted to compare our interventions with the evidence-based practice guidelines. So this is based on Aspen guidelines, the evidence analysis library, the nutrition care manual, and actually the Canadian clinical practice guidelines, which had a lot of really interesting information. So our first intervention was using the Penn State formula to assess energy needs, and we reassessed them daily. So the evidence analysis library did recommend the Penn State, so that we were correct there. However, Aspen doesn't quite recommend not using the Penn State, but said it's no more effective than just using like the Mifflin St. Jean if you can't use indirect calorimetry, which I found very interesting. And that was even in the critically ill patients. However, the nutrition care manual also recommended Penn State, and the Canadian clinical practice guidelines said there's not sufficient evidence to really back up any of these formulas. So I found that pretty interesting, but I still think that the Penn State formula was the right one to use. We also did, every time we changed the tube feeding rate, we reassessed protein adequacy, and we had that at 100%, 99%, and we used the weight-based equation, 1.2 to 1.5 grams per kilogram ideal body weight. We used ideal body weight because he was obese, and we used a higher amount because he was critically ill. So the evidence analysis library says, and Aspen both tell you to keep on evaluating protein adequacy. Nutrition Care Manual recommends using nitrogen balance, which we did not. The EAL also says protein intake of greater than 2 grams per kilogram body weight is associated with positive nitrogen balance, which we did not use. I don't know if that would have worked out well for him because of the kidney injury. And then Aspen recommends to use the standard ICU recommendation of 1.2 to 2.0 grams per kilogram ideal body weight in the obese, critically ill patients with an AKI. Nutrition Care Manual also says 1.2 to 2.0, and Canadian Clinical Practice didn't have evidence. So I think that we were fine there in the 1.2 to 1.5. We also initiated the enteral feed within 48 hours, which everywhere across the board recommended 24 to 48 hours. We withheld nutrition support for the first 2 days because he was not hemodynamically stable. So he did become hypotensive after the tube feed initiation, but it resolved without any signs of like gut ischemia, which is what you really want to look out for when you're worried about the hemodynamic like changes. And on the day of that we initiated, he was not on any like vaso affecting medications, so he was on norepinephrine, although he was later put on it. So everywhere basically says hold enteral nutrition until they're hemodynamically stable, and Aspen specifically says do not start in patients that have the catecholamine agents, so that's like the norepinephrine. So I'm not sure if we should have held the tube feed when that happened, but I think because he was stable when we started, it was okay. So we also fed him per the hospital's vent protocol and the MD recommendations 2 days after he was admitted to the ICU. So the EAL says that that is appropriate. Aspen says that it's appropriate for patients with acute renal distress syndrome or acute lung injury, which our patient did have, or those expected to be on the vent for more than 72 hours, which he was. They also, the Nutrition Care Manual recommends this too, and the Canadian Clinical Practice Guidelines strongly recommend the use of enteral nutrition over parenteral in critically ill patients. We checked the tolerance each day after we initiated the feed, and he was tolerated fine. He had minimal residuals, regular bowel movements, no vomiting. So Aspen defines GI intolerance as vomiting, abdominal distension, high NG output, high residuals, diarrhea, reduced stool size. Also, his bowel sounds were fine, and his abdomen was not distended. So the Nutrition Care Manual, so to monitor stool output, gastric residual volume, basically all the same stuff. And the Canadian Clinical Practice Guidelines, interestingly, wanted us to check for gastric residuals every 4 to 8 hours per protocol, which I guess they did because the nurses would check twice per shift. So this is the one intervention that didn't match up with guidelines perfectly. We've used the Glucerna 1.5 formula at a rate that met 100% of the patient's needs. Aspen actually recommends using standard formulas in critically ill patients, so like not the specialty for diabetes or anything like that. So that was very interesting. They said to avoid the use actually of specialty formulas, they do recommend the energy dense, so we were right on the 1.5 one for the fluid restricted patients, which our patient was, and for those with acute respiratory failure, volume overload. So we were right there, but I guess they would have rather us use like a Jevi kind of thing. And the Nutrition Care Manual recommended using concentrated formulas, which we did correct. The Canadian Clinical Practice Guidelines actually recommended the immune enhanced formula for patients with lung injury or respiratory distress. So I guess we could have done a better job in picking our formula. However, I looked more into this and I couldn't really find the reasoning behind the recommendation for the standard formula over the Glucerna. So I guess all that I really read was that they want MDs to use insulin more to control the blood sugar when they're critically ill, but I don't know how the Glucerna could have harmed the patient. I don't know if maybe it's just for cost that they recommend the standard formula. That's something that I would definitely like to find out more about. So if anyone has information on that, please reach out for me, because even when I presented this to my the RD team, they were all kind of looking more into that too, because they always use the special